Good afternoon, everyone. It is noon on Friday, July 24th, and time for our novel coronavirus update for clinicians. We're glad that you're able to join us. We have moved these webinars to every other week now, so if you were looking for us last week, it's we weren't there, but now we are. And we'll be doing these every other Friday going forward until y'all tell us that this information is no longer helpful, and then we'll quit. But for now, here we are. So I'm Dr. Michelle Fiskus. I'm the Medical Director of the state's Vaccine Preventable Diseases and Immunizations Program. And with me today, again, one of our very favorite people, Dr. Carol Levinson, who is Deputy Director of the Division of Laboratory Services at our State Public Health Lab. And we're going to do some deep dive updates on testing a little bit later on today. Every week we ask you to pick up your device, log into menti.com, and play along with us and give us a little feedback about what we're telling you and who you are and whether or not you've been to these updates before. So if you wouldn't mind going to www.menti.com, and if you enter the code 531618, then you can answer our questions. There's not very many of them. I think there's 5. But for one, it really makes me feel better because I feel like people are actually out there listening to what we're saying, which is great. And 2, it gives us some information about how you are doing. And then 3, the last slide asks about the things that you want to hear about. So that really helps guide us to understand who is tuning into these webinars each week or every other week, and the topics that you're interested in hearing about. So the first question is, what frustrates you the most about this pandemic in one clean word? And the first person who answered gave us 4, but they are clean, so we'll take that, and it is masks not being worn, and probably everybody's going to have a similar response, but we invite you to go ahead and participate in these questions as you log on today. So www.menti.com, enter 531618, and give us your answers. And you can do these at your speed as we go through the talk today. So we'd also like to know who you are, so whether you're a physician, what type of physician, if you're in public health, or a nurse, if you're a pharmacist. If you'll also let us know who you are, that also helps us understand how to tailor these talks. And then, have you ever attended one of these Friday updates before? And then looking at our stress levels. And as you enter who you are into this will break out by how you've identified yourself and give us some understanding of what it's like for you out there. I know as the weeks go by here, things become more and more stressful, I feel like, and not less and less. So it's always good to see what's going on with all of you as well. This is a snapshot of where we've come from. So back in April, we still had about a fourth of us saying that we felt pretty good, and 62% that were stressed, but it was manageable. And you can see a month ago, just a little over a month ago, how that curve had shifted towards I'm pretty stressed, with a lot more people who were feeling super optimistic, and starting to get some folks who were really starting to feel overwhelmed. So I always like to remind you each week about the physician support line. This is a national line that's staffed by psychiatrists who volunteer to talk to their physician colleagues and provide support. I checked last night, the line is still open, and it functions from 8 a.m. till 1 a.m. Eastern time, 7 days a week. So if you need to talk to somebody who is understanding what all of this is like for those of us who are physicians, you're welcome to call there. And then the state of Tennessee also has their Tennessee Healthcare Worker Emotional Support Line. So if you're involved in any phase of the pandemic response on the healthcare side, you can call 888-MHART, H-A-R-T, M-H-A-R-T, TN, which is 642-7886, and that line is available 6 a.m. to 10 p.m. Central Time, where a behavioral health provider who has volunteered to assist can talk to you about some of the stress and emotions that you're feeling through this. So we stood up our incident command here at Tennessee Department of Health and our State Health Operations Center on January 15th, which feels like years ago at this point. 191 days ago is when we began our planning to respond to this pandemic, and it's been 141 days since Tennessee saw its first case. And so now we've traveled through more than half the year working on this pandemic. As always, we have a 24/7 line available for public health emergencies, and that's 615-741-7247. One of our fine physicians or epidemiologists will answer your calls no matter what time you call. If it's not an emergency, you can wait till morning. That's fantastic because we like to sleep too. But we're there if you have rabies questions or carbon monoxide poisonings or some concern about a patient who might have an infectious disease process that concerns you from a public health standpoint, then we're happy to assist you. So this is where we are globally now, and I think perspective is really important. So this is 2 weeks ago today was the last time we talked. So as a globe, we're up a little over 3 million cases in the last 2 weeks, and coming up on 80,000 new deaths across the globe. And the global Epi Curve is not looking good. We were doing okay up until a couple of months ago, and then really started to take off, and it's not showing any signs of slowing now globally. For those who like to say that this is that the flu is deadlier than SARS-CoV-2, now that we have 633,000 global deaths in 6.5 months, we have well exceeded the 2009 H1N1 global deaths, which was about 500,000. With 136,000 U.S. deaths in 5 months. We have beat all of the pandemics now with the exception of the 1918 H1N1 avian flu. So we are, well in the thick of this, and, certainly difficult to say that this is less deadly than the last 3 pandemics that we've seen. This is where the United States is. So again, from 2 weeks ago to now, we're up almost 1 million cases. We are growing exponentially now, 11,000 new deaths over the last 2 weeks. And note that deaths per capita number in the middle of the black bar on the bottom line. We've gone from 38 deaths per capita to 41.3. This was ticking up kind of slowly initially, but we've started to see this number in particular really start to increase. When you look at the graph on the bottom, we're the orange line that was starting to decline in June and then took a rapid upturn middle of June, and here we are at the end of July now and still climbing at this point. The green line is Brazil, which for a little while had come up and passed us, but they've actually managed to flatten their curve. And then the more red line towards the bottom is India that's coming up, but the slope of their line has started to flatten out a little bit, so maybe they're going to start to get ahead of theirs. So we talk about flattening the curve. These are the new daily confirmed cases with the 5-day moving average. So on the left side is the United Kingdom, which started right around the same time we did. We're just about a week off of each other, with the United States jumping in, 9 days earlier than the UK. And don't look at the numbers because the UK has about 1/5 of our population, but just look at the curve. So this is what an Epi curve should look like when you're starting to get ahead of a pandemic versus what's happening in the United States, where there's just no real hint of that flattening off and coming down the other side of our curve at this point. Do know that the UK deaths we're at 45,000 for their population, which is, as I said, 1/5 of ours. So, if their population was like ours, they would be sitting at about 200,000+ deaths at this point. We're at 143,000, but also not moving in the right direction at this point. Here's what the states look like. Mississippi has taken the lead for badness at this point. You can see all of the Epi curves of all of the states. And looking up at the northeast, Massachusetts, New York, Connecticut, all of those states that have had these nice Epi curves that we really like to see. Disease comes up, disease goes down, and then all of the southern states that are largely still in an upward trajectory there, with Washington, D.C., I think, is the one that's down there that's had this new blip. They were doing okay, and now we've got this increase. And then Louisiana that had a peak and now has just kind of taken off like a shot there. So I want to talk a little bit about testing versus percent positive, because we hear a lot of talk about, our positive case numbers are going down, or our positive case numbers are going up. And you really have to look at a lot of different parts of this to really understand the picture. So I picked Arizona, which has the highest percent positive rate in the country right now at 24.7. So if you look at Arizona's number of tests per 1,000 residents, they're at 1.5. And then I picked New Jersey, who's at 1.6. And so this is the number of tests per 1,000 residents. And so they're fairly equivocal. And then you look at their percent positive, so 24.7% positive in Arizona versus 1.4% positive in New Jersey. And if you're looking at this and saying, well, the testing is at similar rates in both states, but we've got 20 times the number of positive tests in Arizona than we do in New Jersey, what they're seeing is an increase in the number of cases that they have in Arizona. It's not that they've done more testing and so they're identifying more cases, it's that they actually have more cases in Arizona. The comparison to this, for us would be New York, that has about 3.3 tests per 1,000. We're at about 3.5 tests per 1,000. New York's positive test rate is 1.1% now. Ours is 9.2. So same rate of testing in New York as in Tennessee. New York has come down the other side of their curve. As you remember, they were the U.S. hotspot in all of this. Now at about 1% of those that they're testing, still at a good rate of testing, are positive, but we're looking at getting up onto 1 out of 11 of those people who are tested in Tennessee are positive. So it's not more testing, it's more people that are actually infected with the virus. This is what our state's Epi curve has looked like. So a mark there where the stay-at-home order expired at the end of April, and then we had a little decrease in our case counts there. The lowest we got to was 3.3% new cases, and now we're at 9.2. So the World Health Organization really wants to see us below 5%. We're at nearly double that now and have had a pretty consistent uptick since the end of June now with the cases in Tennessee. Every day at 2 o'clock or thereabouts, we post our new data on our website at tn.gov/health. So in 2 weeks, we've gone from 57,000 cases to 86,000 cases. The deaths have gone up by 215. I should write these things down so I don't have to try to math in my head on a live webinar. And we're at almost 1.3 million Tennesseans who've been, we're at nearly 1.3 million tests that have been performed, which is different than the number of people who've been tested. Hospitalizations are up by 1,000, so 25% in 2 weeks, which is a really concerning number, and you can see the map with the county counts here. The top curve is what our state Epi curve is looking like. We're not yet seeing any indications that we're moving in the right direction here. Our hospitalizations are at their peak so far at 1,040 hospitalizations right now, and we're starting to see some hit to the floor beds and ICU beds. We've been pretty consistently in the 20–25% range. We've been kind of bouncing back and forth between 16 and 20 over the last couple of days now, I would say over the last week or so. And we have about 66% of the available ventilators still available. And then what's interesting about our deaths is so we're at 80% of our deaths are in those over the age of 61. And at the beginning of this, we were closer to 90%. So we're seeing more deaths in a younger population now, with even the 11 to 20-year-olds starting to come up a little bit, but a big increase in the 41 to 50 age range, the 51 to 60. And so fewer of the very elderly folks, and that's largely because of the safeguards that have been put in place to test long-term care facility employees every week, to limit visitation at nursing homes as they're the most vulnerable population. Our case fatality rate, so the percent of cases who die, is at 1%, which is good. That's lower than it has been. With 6.3% of those who test positive dying if over the age of 61, and 18% of those who are residents of long-term care facilities having a fatal outcome if they're infected. And then we're seeing this climb in the percent of cases that we're seeing in the 11 to 20-year-olds, coming up to 10,000 pretty soon here. So we had really low numbers in youth, and now we're at 16% total. So we continue to see an uptick of about an increase in about 1% every week to two over the last couple of months now. So a few headlines and hot topics for the last couple of weeks. So on July the 3rd, the governor granted the mayors in the 89 rural counties authority to issue mask requirements. The other 6 counties of our 95 are in the metro regions where they have their own jurisdiction with their own municipally elected leaders there. So they're not Tennessee Department of Health jurisdictions. Since that time, there are now, as of yesterday, 21 of the 95 counties that have mask requirements, and those 21 counties cover 64% of the population of Tennessee. So moving in the right direction with that, thankfully. There was a study that came out last week about the exposure in a hair salon of 2 hairstylists who'd been exposed, their clients had been exposed, and seeing that while they had contact with 139 clients over a period of the couple of days that they were working while infectious, they actually infected no one using face masks. So more evidence to support the idea that we need to be using face masks universally so that we can get ahead of this. And in the absence of any other real strategies except for wearing face masks and distancing, it's really the only thing that we have in the arsenal right now. There was also a study that came out, or a research letter that was published in JAMA last week. This is out of Mass General, and so they instituted a universal masking policy in Mass General back in March or April, I guess, end of March, where they decided that first they were going to have universal masking for all of their healthcare workers, and then they were going to have universal masking for all of the patients as well. And they did find a significant decrease in the chance of a healthcare worker becoming infected with SARS-CoV-2. So more support there for the use of masks. This particular study, these were surgical masks that the patients and the staff were using, but they weren't N95 masks on the healthcare workers. They were just surgical masks, and saw a really nice decline there. AAP just a couple of days ago released their return to sports during pandemic guidance for pediatricians. So what they are recommending is that there not be testing before sports participation unless we have an athlete who is symptomatic or has had a close exposure. that any athlete who tests positive, even if they're asymptomatic, needs to have physician clearance before they return to play, and they need to be out for at least 2 weeks. And then if they're severely ill, they're to be treated as a myocarditis patient and restricted from participation for a minimum of 3 months and need to have a physician clearance to return to play. And they recommend that we avoid travel to other communities and regions for sports. So I gave you the link here for that report, but you can also just Google AAP News to find the full publication for that. And then there was a preliminary report that just came out last week on the Moderna mRNA vaccine phase 1 clinical trial. So that was a trial of 45 participants. They found no safety concerns. Typical vaccine reactions, they did have some people that got fever. Most of the reactions were with the second dose of the 2-dose protocol. They did find neutralizing antibodies after the second dose, but not really after the first. And those neutralizing antibodies reduced infectivity of the virus by more than 80%. And they found binding and neutralizing antibody titers that were similar to what we see in convalescent serum specimens. So that's encouraging news. They're going to follow those patients for a year, but they have their phase 2 trial ongoing. They're currently enrolling the phase 3. Vanderbilt is doing that trial, so if you want to go on to just Google Vanderbilt vaccine trial if you want to sign up for that. They are currently collecting interested folks, and then they'll reach out to them to enroll, but I'm sure they would appreciate hearing from you if you're interested in participating in that. So, you know, this is encouraging news. What we still don't know is if this antibody is going to stick around, and Dr. Levinson is going to talk a little bit more about that in just another couple of minutes. And I just wanted to bring to your attention this MMWR pod series that's out, where they talk about weekly updates on the latest information around COVID-19 response. So check that out. MMWR always has really great information in it. Many of us are too busy to sit down and actually be able to give it a read. So this is one way to do it in your car, maybe on the way to the office, where you can take a listen to that. So I'm going to turn things over to Dr. Levinson, who's going to talk about testing and testing and testing, because that's always the hot topic. And we're excited to have you back and tell us what new things you know.
Well, great. Thank you again for having me. We have been doing a lot of testing. Certainly hasn't gone down for us. And happy to talk about new developments as they come our way. So today I'm going to talk to you kind of about 2 topics. One, pooled testing. And the other, I'll share an update on a paper looking at antibody responses that Dr. Fiskus alluded to earlier. But we can start with pooled testing. I wanted to mention it because it's a hot topic, at least on the laboratory side of things. I've heard it talked amongst leadership and politicians at the local, state, and even federal level as one way to address the testing capacity challenges. And it is a strategy that's been employed by other laboratories, other state public health laboratories, as well as commercial and private laboratories. So I wanted to touch on it a bit and just kind of explain what it is and tell you a little bit about what we're doing with it in our state, Tennessee. So to explain pooled testing, what helps is context and knowing what normal testing is. So routine testing for COVID-19 starts with a sample arriving at the laboratory. We extract the RNA from the sample, and then we test to see if that RNA happens to come from the SARS-CoV-2 virus. And then we send out a report that goes to the provider and eventually to the patient. The difference with pooled testing is you take multiple samples and you put them into a pool. So rather than testing one sample individually, extracting it, testing it, and giving out one result, this is a way to optimize lab reagents largely. That's kind of how it started out. And I should mention, pooled testing is not a new concept to most laboratorians. It's been employed largely in the STI field. Early in the HIV epidemic, it was used because the laboratory supplies and reagents were so costly when HIV was brand new that this was really the only way that labs could do the testing, is by combining samples into a pool, testing them, and then going back and retesting them if they were positive. So The way pooled testing works, the name pretty much gives it away. You take individual samples, you combine them into essentially one tube or one pool, and then you test that one pool. So you do one test even though you've combined, say, 5 samples into it, and then you get a result. And so if that result is negative, you can assume every sample that was put into that pool was also negative, and you report that out. So this is where you get that savings in lab reagents and time, because you can very quickly test 5 samples essentially at once and get those results out. However, if you test that pool and it's positive, you then have to go back to each individual sample and test them individually to see which one was positive. In this example here, there's one of the 5 samples that was positive, but you certainly could have 2, 3, even 5 samples positive. And so this is where positivity rate plays a big role in whether or not pooling is a good use of your laboratory time and resources, because if there's a high likelihood of those samples being positive, then you actually don't get any reagent savings, and you actually end up taking more time because you're having to go back and retest all these positive pools. So it's a pretty straightforward concept, but it can be used, you just have to use it kind of thoughtfully, and there are some definite limitations to it as well as some benefits to it. One thing to keep in mind is you do get slightly lower sensitivity in your test because you're literally diluting it by combining it with other samples. So if you have a sample that happens to be a very low level positive, by diluting it into a pool with 4 other samples, for example, you could actually have it dip below that level of detection. So there is a risk there, and it's something laboratories look at before implementing the method. The other thing to keep in mind is there really is no benefit to use pooled testing if the prevalence in your population is high. Typically it's around 10%, so with all the data that Dr. Fiska shared, you can see how Tennessee is right on that cusp of pooling not necessarily being useful until our positives go down. And it's really because if you have a certain number of positive pools and you're having to go back and retest, you don't get any real benefit from it in terms of speeding things up or having your reagents be able to stretch further in the laboratory. Notably, it doesn't necessarily reduce turnaround time. If they're negative, it can speed things up, but there is a higher burden on kind of the pre-analytic and post-analytic side of things. So while it can be faster for the actual analysis, if most of your pools are negative, it does take more work and staff time on the front end to kind of combine those pools. And then on the back end, when you have the results, making sure you're resulting things out. You know, if you have one pool, making sure 5 results go out and that they're cross-checked and correct. And if you have a positive pool, you know, you then have 2 results for each sample. So certainly not impossible, but does take time. So you may not get a net reduction in turnaround time when it comes to getting results if you do pooled testing. The other thing to keep in mind that we care about from the lab side of things in terms of quality controls, most COVID-19 tests and most tests have some sort of internal control to make sure the swabs that we're getting were actually put in someone's nose or throat. So there's generally an internal control that looks for human DNA just to make sure something was actually swabbed. And when you pool things, because you're pooling these all together, I don't know if 1 out of those 5 swabs didn't actually get swabbed. You lose the ability to look for an internal control to look at specimen quality. So something to keep in mind. As well as there's just a higher risk for contamination. The more you manipulate samples, the higher risk for contaminating other samples that may be negative with a really hot positive if you're putting them all into one pool and you have to go back and reopen them to retest them individually. These are all just things that we consider on the laboratory side of things before implementing it. So those are kind of the limitations, but there's also some very real benefits to it. The biggest one to the lab folks is we can stretch our lab reagents supplies further, and in an age where our supply chain is really dynamic and questionable and just really hard to predict right now on multiple test platforms, you know, being able to stretch those reagents further by doing pool testing is important and useful. It's also a really good way to effectively screen large numbers of people or samples, especially if they have a high likelihood of being negative. So this is helpful for screening, you know, potentially students or businesses where people are asymptomatic and chances are they are going to be negative. This is a great way to kind of quickly screen them and get a result. Where it's not helpful is if you have a cluster or a population where you think they have a high likelihood of being positive and say like a nursing home, pooled testing would not be appropriate then because you have a higher likelihood of being positive, which means you have a higher likelihood of positive pools and having to go back and retest things individually, and that just makes more work for everyone and slows things down. So it is important to know on the front end kind of what the pre-test likelihood of samples being positive. It's also helpful in identifying asymptomatic carriers in a population. Again, if we're screening large numbers of people that should be asymptomatic, they still very well could be carrying and transmitting the virus, and pool testing is a way to identify those, even if they're not symptomatic. So, like I said, pool testing is great when used appropriately, but you just have to be careful in how you choose to employ it. I did want to mention the FDA last Friday issued their first emergency use authorization, or EUA, for pool testing. That was with Quest Diagnostics. And I know more manufacturers are in the works of submitting or amending EUAs for pool testing. It's something a lot of labs are looking into, both on the commercial side as well as public health laboratories. And if you're interested in it more, I wanted to share this paper here. This is out of Nebraska. Their state public health lab has been doing pool testing since essentially the beginning of the pandemic, again, due to limitations on supply chains and getting reagents for the laboratory. So they're really the experts and have led the way on this. So if you want to learn more how they did it, it's a great paper to look at. Because really what governs all of this is knowing the positivity in your population, and that guides how big your sample pools are, how many samples you can put into one pool, and whether or not it's worth your time. Because again, if it's over 10%, more often than not, or often enough to where your pools are positive and it's not a good time saver or reagent saver. I did want to mention this is something the State Public Health Lab here in Tennessee is moving forward on, where it should be going live with pool testing in the very near future. We're aiming for next week. So again, it really depends on the population that we're testing, but it is a strategy we're looking to employ among Tennesseans to help address our testing needs. So with that, I wanted to kind of switch gears and quickly talk about a paper that recently came out. I thought it was really interesting because there's so much talk about vaccines and antibodies, and it's really just a question of, will these antibodies that people get, whether it's through a vaccine or natural infection, is it going to save us? And that's what this paper tried to address. And it's one of the first papers I found that really looked kind of more longitudinally or longer than more than like 30 or 60 days. That's the challenge with a novel virus, is to look at these long-term effects. You need time to figure that out. So this is one of the first studies that looked out to about 100 days. And it kind of broke it down into two groups of individuals that were symptomatic and PCR confirmed to have SARS-CoV-2, as well as seropositive healthcare workers. And they looked up to 90 days post-onset of symptoms to kind of get a sense of the kinetics of the neutralizing antibodies, how they developed, the magnitude at which they developed, and the durability and how long they lasted. And I should mention this came out of a group from King's College in London. They do a lot of immunology and serology and vaccine development work. So I'll start off with the good news, and we've seen this echoed in other studies that have come out. The good news is you do see seroconversion in the vast majority, 95% of cases, and you do see the production of neutralizing antibodies. So here this is against a couple different targets like the spike protein, the something binding domain, and the nucleocapsid is the N. So we looked at a number of different targets, receptor binding domain. Sorry, that took me a second to think through. But they looked at different antibody responses, including IgM, IgA, and IgG. And you pretty consistently saw against these just different proteins a strong antibody response over time. Interestingly, and we've seen this pretty consistently across the board, you see IgM and IgG come up at roughly the same time. They seem to pair pretty well together when it comes to SARS-CoV-2. So that's the good news, is you do get an antibody response. So the bad news is they don't necessarily last very long. So here they looked out to about 100 days, and they saw, in general, kind of just a decrease across the board in how long the duration of those neutralizing antibodies. Here in this graph, you can see some black lines and some red lines, and they kind of differentiated the people based on the severity of their symptoms. So the folks in black had either no symptoms or very mild symptoms, and the folks in red had pretty severe symptoms. And what you can see is everyone decreased across the board. But what you can also see, and this is kind of the interesting part, is that the magnitude of the neutralizing antibody response kind of correlated with disease severity. So you got more antibodies if you had more severe disease. And this has a number of implications when it comes to how people respond when they recover from infection, their likelihood of getting reinfected, and also potentially how people might respond to a vaccine. So there's good news, there's bad news, and then there's interesting news, and we really just need more information moving forward. So this was an important paper and kind of gave a glimpse into kind of the longer-term effects of how our antibodies respond to this virus, but we still have a lot more questions than answers. But would definitely recommend you read this paper if you've got more interest in it. It's pretty well done. And that's it for me.
So I know that at one point you all were doing some antibody surveillance testing for healthcare workers just to kind of see what the prevalence was. Is that still ongoing?
Yeah, ongoing in the sense that we're done doing the testing and working on writing it up. So we are looking to publish it, and it is based on folks here in Tennessee, so I'll be happy to share that when that's more ready to come out. Yeah. But the testing is complete. Not to give too much away, but we tested, I think it was close to 12,000 people. They were frontline healthcare workers across the state at a number of different teaching hospitals. We actually had a pretty low number of seroconversion. It was less than 1% were seropositive. We only have PCR information on some of them, so those that did get PCR tested and were known to be PCR positive or negative, we are looking at that data to kind of pair it with the antibody data. That wasn't for every single one of those nearly 12,000 healthcare workers, but it's interesting, and it was kind of surprising that it was so low. So more to come. We're still kind of crunching the numbers, but I will definitely keep you all posted because it'll be interesting to see how it plays out here in Tennessee.
Yeah, definitely. That's really that's exciting and intriguing to hear about. Yeah, we still hear a lot of folks saying, oh, well, everybody should just get it because then there'll be herd immunity, and of course, those are people who often don't believe in herd immunity. So it's interesting, this dichotomy there.
You can pick and choose what you want to believe in.
Well,
right?
True, right. And so I think the latest numbers I saw were that they anticipate we need 60 to 70% to achieve enough herd immunity to be able to stop this pandemic, essentially, if the distancing and the masking and all those things aren't put into place. And so that ends up being a tremendous number of, community members, Tennesseans, people in the United States, we're talking millions and millions of Americans who would not only get infected, but also millions of them who would end up dying as a result of COVID-19 while we're trying to achieve herd immunity with an antibody that may not even, last more than a season. So,
yeah, it's certainly helpful to know how long they last, because if we're going to get to those needed levels of herd immunity, it has to be all hands on deck all at the same time, because if you don't get to that level, then there's plenty of room for this virus to maintain itself in the population.
Yeah, exactly. Well, we're going to get to your questions in just a second. I have heard some of you have reached out to me on social media asking how to get PPE, and you still can do that through TEMA. So if you are in an office practice where hospitals get their own PPE, but if you're in a small practice somewhere or a community health center or something, and you don't have access to PPE and you've tried your local emergency management agency and haven't been able to get assistance, you can try going to this website and putting in this passcode. If you request no more than a 2-week supply, don't get greedy and try to get a bunch of stuff, but they do have N95s and surgical masks and gloves and gowns and face shields, and they can send small quantities of those out. So you go into the survey, put in your organization type. If providers are still not listed there, just put yourself under other, and then request what supplies you need, and you should get a shipment of those. Usually we've seen that within about 2 to 5 business days. So give us some feedback if you haven't, if you've tried this and you haven't received it. If a couple weeks go by and you haven't seen anything, try again, and it may be something that gets you what you need. So we're gonna, oh, look at all of you who put in stuff for next time. That's awesome. Keep doing that, because those are always fun to watch in these word clouds. Okay, so first question, for MDI use instead of nebulizers, which is what's recommended so that you're not doing aerosolizing procedures in your office, how are some ways to provide treatment to acute pediatric practices? Do you know of any resources to get supplies to provide MDIs in these acute cases, and is there a way to bill for it? So it's a good thing. I think coding is sexy, so yes, there is, and I looked it up to just verify. So the same code that you use to bill a nebulizer, the 94640 CPT code, is the same one that you use to give an MDI treatment. So it's the same thing. You cannot bill for the medication because that's wrapped up into the bundled code, but if a healthcare worker administers the MDI puffs to a patient, then you can bill for that, the 94640 code. You can't get insurance or anyone to pay for the MDI. Many of the MDI companies will send samples, so you could get a sample that you could use in your office. You could try to get samples that you use for that individual patient and then give to that individual patient when they leave. Or you could write a prescription to the practice and send that to a local pharmacy, pay for it out of pocket, and then bring it back. What you would probably want to do if you're going to use that with multiple patients is to remove the cartridge that's in it, thoroughly clean the actual plastic thingy that you stick the cartridge in. And I never know the actual name for the delivery thingy, that you stick a, you know what I'm talking about. Anyway, that thingy, spray it with bleach or wash it in hot soapy water or something between uses, and then you should be fine to put the cartridge back in it and use those for another patient. Obviously, you probably don't want to be sharing spacers unless you're going to be able to disinfect those. But you can bill for it and hopefully get your money back for the amount of money that you spend on the MDI. Second question, does the health department inform the education department in guidelines, or does each district do what they want? So the Tennessee Department of Education does not have any kind of jurisdiction over local school districts. So there's no authority there to demand or require anything. And so the school districts are really, their guidelines are decided by their superintendent, sometimes with their board involved, sometimes not. It just depends. They would need to comply with whatever local municipal rules are in place. So if they're in a county that has mandatory masking, then they would have to comply with that. But the Department of Education can't do anything but make suggestions. And it's same for Department of Health. We also can't mandate anything or ask that local educational authorities require anything. We can make suggestions based on best practice and pass along CDC information. The only thing that we can really get firm in language with is quarantine and isolation, because the Department of Health does have legal authority to be able to order someone into quarantine or isolation. Obviously, it's something the Department of Health doesn't like to have to do, but it's something that can be done in situations where the risk to public health is high. So, to the first part of the question, yes, we do work closely with the DOE to help inform their guidelines, and we've developed some documents that we've provided to Department of Ed to help get information that's needed out to the districts. We've seen a lot of district plans that suggest that quarantine is optional, or that someone who's been exposed can return in a couple of days if they have no symptoms. And we're working hard to try to get the information out so that those types of policies don't get put into place. Can you comment on studies suggesting BCG, which is the tuberculosis vaccine that is not used in the United States, and MMR vaccine may offer some coronavirus protection? So there's been a few limited studies that have come out. It's not the first time that BCG has been suggested to prevent other types of diseases outside of just tuberculosis. They've identified that there's a 30 amino acid sequence that is in common with the rubella envelope glycoprotein and also with the measles glycoprotein. So the thought is that, is MMR vaccine conferring some protection or maybe making coronavirus infection less severe, and is that why children are not getting infected? There are a lot of other theories about why children don't get infected that have to do with the presence of certain receptors. So there's a lot of theories out there. In kids it's difficult just because it's so hard to limit the variables and to know, is it because they're so much shorter than adults and so they're not face-to-face with people and it's harder to get infected? I mean, is it because of the environment they're in? Is it because of where their immune system is in development? There's just so many different things. So yeah, there's been some suggestions about it. I think the things that go against that are for one, the curve that I just showed you of India, that where BCG is used in India as common practice, and we're now seeing the pandemic really start to rear in India at this point. With respect to the pregnant women that we see that get infected and then go on to die, most of them have rubella titers that are drawn when it's discovered that they're pregnant. And so if they don't have rubella titer, then we should know that information if they end up succumbing to COVID-19. So we should be able to tell that is an adult who gets a rubella titer, which is pretty much the only population where we'll see that outside of an epidemic. So at this point, I would say look at those studies skeptically, just because it's so hard to control for the variables. That said, if that makes people go out and get MMR vaccines and stop skipping them for their kids, then I'm all about it. What is TDH doing to expand contact tracing in the state of Tennessee? So typically when we have a highly infectious disease like this, the Department of Health will be notified and they would contact any positive case, contact all of their contacts to make sure they're quarantining, and then they would do monitoring throughout the isolation and quarantine period for those individuals. As I'm sure you've all seen, we've been running 1,600 to 2,400 new cases a day for the last several weeks, and there is just not that kind of staff to keep up with the ability to do that. So the state has contracted with a multitude of folks who do nothing but call positives and try to assist with contact tracing and monitoring. It is a daunting task for them to do, but they have hired hundreds of people who are working on that now, and I think most states are in that basket where they're in the process of trying to get those folks on board. As face shields have become a more visible part of PPE, many folks, some school administrators and non-medical companies have been thinking a face shield can replace a mask. What is Tennessee Department of Health doing to educate on this point? So yeah, we are seeing a lot of that, a lot of talk in schools and universities about wanting to use face shields, which are not suitable for, in replace of a face mask. So face mask protects the people who are around the wearer. Face shields protect the wearer, specifically protect their eyes from exposure to droplets. So they can be used in concert, but face shields should not be used without a mask. There are some face shields that have been developed where they wrap the sides of the head and come down much lower, and they may provide a little more protection to the people around the wearer, but CDC is pretty strong in that they are not to be used instead of a cloth face covering. So we're trying to amplify that message. We do webinars with colleges, and I've been on a couple of superintendents' calls that are statewide, and in trying to reinforce that point. If someone is absolutely positively going to refuse to wear a face covering under any circumstances, then, you know, is this a good is better than nothing? Possibly. I guess people could make that argument, but we definitely want to continue with the message that people absolutely need to wear a face covering. The next question is there a positivity level that will force mandated masks? Or will that never happen? So I think the governor's been pretty clear that he is not going to force a mask mandate, but has left that to the county mayors to decide on what they want to do with that. I think that was originally going to expire after 2 weeks, and they have extended that now. And I'm actually not sure when the end date is on that current order, but I think the governor's been pretty clear about his support for the wearing of face coverings.
Next one's for you. Sure, I'll take that one. The question is, how do healthcare workers get in on the study of antibodies? Great question, and I can follow up with an answer. That initial study that I mentioned has been completed with the nearly 12,000 frontline healthcare workers. We're crunching the numbers and writing that paper up, but the State Public Health Lab here in Tennessee does have the ability to do additional antibody testing. We currently test for IgG antibodies to COVID-19. So I will follow up in terms of checking with our leadership and our testing strategy moving forward. Certainly, I think there's a need to continue testing healthcare workers and looking at their antibody levels. So I don't know right now what that answer is, but I will follow up and I'll make sure I share that information with Dr. Fiskus for the next webinar.
Great. Someone says they've been receiving supplies from TEMA. Yay, that's great. And the gowns they were supplied did not clarify if they're fluid resistant. How might I find out? So I actually am embedded part-time over at TEMA, and I'm privy to some of these conversations. And so they're very careful in making sure that we are only procuring gowns that are made of material that are fluid resistant. And I mean, these are splash resistant gowns, not go soak in a tub fluid resistant gowns. So, but they've all been examined to make sure that fluids bead on them and come off and don't soak in. So you should feel comfortable that the gowns that you're getting from TEMA, although they may be sourced from non-traditional places, they've all been checked to make sure that they're going to protect you.
And I can take the next two. The next question is, do you listen to TWIV, which is a podcast called This Week in Virology? Episode 640 mentions rapid antigen testing and how a $1 daily antigen test could be a way to safely reopen schools and the economy. It was very good. I am familiar with that podcast. I'm a big fan, like longtime listener, no-time caller. So it's a podcast series, actually. They have TWIV, which is This Week in Virology, TWIM, which is This Week in Microbiology. They have TWIP, which is Parasitology. They have a number of other really good podcasts. They have a Meet the Microbiologist that does interviews of, big fan.
Obviously.
Put together by the American Society for Microbiology. I would also mention, if you're studying for your boards, TWIV and TWIP are wonderful. Big help. Anyway, to get back to this, I am familiar with this episode. They interviewed Dr. Michael Mina, which has been he's a clinical microbiologist, virologist. He's very involved. He's very good. And yeah, he is really pushing that. He also published a paper recently that test sensitivity is kind of secondary to being able to just test often and cheaply in terms of surveillance and kind of getting the economy back on board. So I completely agree. It's a great episode to listen to and could probably be the gateway into the world of TWIV. Highly recommend. And to answer your final question of, do you think rapid antigen testing is something we can make a reality in Tennessee? I think we already are. I know Dr. Fiskus can chime in with the details of it, but it is something we're looking at. Currently, there are 2 antigen tests that have received the FDA EUA, and I know we have at least one of them already in use.
So we have the Quidel test platform that we have been able to deploy to some vulnerable population facilities. So our mental health institutes, the mental health hospitals in the state all have Quidel testing. The DCS congregate care places, we're trying to get some kind of testing to them. Some of our FQHCs, we've been able to help acquire rapid antigen testing, and so that's great. The problem is that both the Quidel Sophia 2 machines and the BD Vector machines, which is the other platform, are now being diverted to the feds because they're planning on supplying one of these machines to each of the long-term healthcare facilities in the country, starting with those that are at highest risk of having cases in their facilities. So our supply chain, we anticipate, is going to dry up pretty quickly and put a cramp on our ability to acquire those analyzers. So those rapid antigen tests are not like the benchtop flu tests or strep tests that you're used to, where you can look at them with your eye and determine, sometimes, if you use those, you know what I mean by that, whether or not it's positive. These actually have to go into a reader for 11 seconds that tells you whether or not it's positive. And so the test cartridges are available, but the machines are not. So that's been a big bottleneck there for us. We're going to, go ahead, Jen, another comment?
Just chime in with one quick answer to the last question is there a difference in quality of molecular testing versus antigen testing? And in looking at the discussion topic for next time, it looks like there's big interest in kind of point-of-care testing and access to the different kinds of tests. So I'm inviting myself back.
Yeah.
I'm happy to talk about that at another time. There is a difference because with molecular testing, they're largely PCR tests. So there's an amplification step to it. So you're looking for a needle in a haystack, and the way that they work is you just replicate the needles and find them, and they're easier to find that way. Whereas antigen testing, you're literally looking for pieces of protein on the surface of the virus. There's no amplification step, so you're just looking for a single needle in a haystack. So there is a difference in sensitivity. Inherently, antigen tests are less sensitive than PCR tests. That doesn't make them not useful.
Yeah.
They certainly have a role to play, and in the thoughts of Dr. Michael Mina, certainly they're cheaper, they're faster, and probably easier to deploy. Sure. So there's a role for every kind of test in this pandemic response.
Yeah, the Quidel just updated their what do you call it, the instructions?
The instructions for use and their performance characteristics.
Yeah, to say that as long as you test with the Quidel within the first 5 days of symptoms, you no longer have to confirm a negative with a PCR. So that was an interesting update. But.
Yeah, I think we'll find a lot more information about them as they get more widely used.
All right. Thanks so much for being here again, Dr. Levinson. I guess we'll see you back in 2 weeks so we can talk about antigen testing. And we'll see you in 2 weeks. I hope you come back and stay well. Thanks.